live?
We are live now, doctor.
Yeah. So very good evening, everybody. On behalf of Team YOSI, the YOSI, the Bio Pearls and YOSI Oculoplasty Focus Group, I, Dr. Nupur, welcome you all for this very, very interesting webinar. So basically, this is the, can we go back to the previous slide? Yeah. So this is basically Pearls in Focus, Oculoplasty Unplugged. So we have a set of, presentation of 1-minute pearls by the young ophthalmologist, and which is being judged and being discussed by a very esteemed faculty of oculoplasty today. So without further much ado, can we go on to the next slide? Slippy. So let me also introduce our team YOSI, the current guard, the YOSI Governing Council, Dr. Devakan Mishra as a president, Dr. Sonal Kalia as the immediate past president, Dr. Karan Bhatia as a vice president, Dr. Nilesh Kumar as a secretary, Dr. Aditya Sethi as a treasurer, and Dr. Prasanna B. Ramesh as a joint secretary. And they're joined by a very able pan-India executive team. And YOSI is currently doing so well because of such a great teamwork, which it is. So today we are also joined by the team lead of YOSI Oculoplasty Focus Group, which is being led by Dr. Puneet Jain, and he's currently a consultant in charge of ophthalmic plastic surgeon ocular oncology services at Agarwal Group of Hospitals, Delhi, NCR. So over to you, Dr. Puneet, to say a few words and just give what about the Oculoplasty Focus Group. Over to you, Dr. Puneet.
Hi, a very good evening to everyone. Special mention for our seniors, Dr. Grover sir, Dr. Usha ma'am, Dr. Marian, my colleagues who have really helped put this together. So this event today combines two initiatives of YOSI together. One is the clinical Yo Pulse that has been going on for quite some time, and the I should say relatively recently formed YOSI Oculoplasty Focus Group, which was an initiative taken under the able leadership of Dr. Devakant Mishra to form these focus groups so that we equally emphasize on each specialty, because all of us have different interests. All of us are now have chosen a subspecialty, and there are so many young ophthalmologists who now have this opportunity through these webinars, interaction with seniors, and these learning exercises to choose what interests and attracts them the best, rather than just uh, going with the flow or under peer pressure, as used to be the scene not very long ago, a decade back, when I was going through this process, and we did not have access to so much learning opportunities, I should say, at the click of a button. So, and at that too in the evening, after you've done everything, so you can sit and learn. So a very warm welcome to the esteemed chair, to the panelists, to all the participants. Special thanks to Nupur and everybody, Dr. Lipi and Dr. Nupur, especially Dr. Olika, for putting this together. I am sorry I'm missing out names. It's a very novel initiative, and I'm sure with the success of this event, we can take this forward for many more such episodes to come. Thank you so much.
Thank you, Dr. Puneet. You've been doing a fantastic job leading the YOSI Oculoplasty Focus Group and giving unwavering support to all the initiatives that we come across. Thank you so much, Puneet. And now we would like to go ahead and introduce our very esteemed panel of chairpersons. So first is Dr. Ashok Kumar Grover, sir. Sir is the teacher of teachers. Sir needs no introduction. Sir was the awarded Padma Shri by President of India, and he's a chairman, Vision Eye Center, New Delhi. He's been on the boards of a lot of organizing societies, oculoplasty societies, and we're so honored and privileged to have you, sir, here today. Thank you, sir, for joining us today.
Thank you.
And then we have Thank you, sir. Then we have Dr. Usha K. Ma'am, another very, fantastic teacher. And so ma'am is currently heading the Department of Orbit Oculoplasty and Ocular Oncology and Ocular Prosthetics at Arvind Eye Hospitals. And she's also the director of the Allied Ophthalmic Personal Training Program at Arvind Eye Care System. Ma'am has a lot of publications to her credit. And then we're also joined by Dr. Kasturi Bhattacharjee, ma'am. Yeah. So, ma'am, Kasuri Bhattacharya, ma'am, is currently the president of AP Sopris and also the president of the Oculoplastic Association of India. And she is the director, clinicals and academics at the Sri Sankradevi Netralaya, Guwahati, India. Again, we're so honored and privileged to have ma'am with us today. Thank you, ma'am, for joining us.
Thank you, Nupur. Thank you, Yosi, for having us here.
Thank you. Thank you, ma'am. Thank you, sir. Over to you, Dr. Tanvi, to introduce the moderators.
Good evening, everyone. Welcome to the session. I am very delighted to introduce our moderators for today's session. We have Dr. Nupur Goel with us. She is currently working as consultant anterior segment in oculoplasty at iCare Eye Hospital and PG Institute, Noida. She's completed a long-term fellowship in comprehensive and oculoplasty from LV Prasad Eye Institute, Hyderabad. Welcome, ma'am. Next, we have Dr. Lipi Mittal with us. She is MBBS MS FAICO Refractive Surgery and FCRS. She is a consultant at Cataract and Refractive Surgery Center for Sight at Palwal. She is also an executive member of YOSI and team lead of Cataract Focus Group YOSI. Next, we have Dr. Yugandhara Patade with us. She is MS, DNB and FPRS. She is currently working as consultant Cataract and Refractive Surgery at Raghunath Netralaya, Mumbai. And myself, Dr. Tanveer Kaur.
Yeah, so I'll introduce Dr. Tanveer, our dynamic moderator for today. So she's currently a junior resident at Hassan Institute of Medical Sciences from 2025 to current. And she's a very dynamic young ophthalmologist. She's a member of the core member of the YO Pearls. Thank you, Dr. Tanveer, for helping moderate and compiling everything so efficiently with Dr. Yugandhar. Thank you, Dr. Tanveer. Yes. Yeah, over to you, Dr. Yugandhar, for introducing the conveners.
Yeah, good evening, everybody. So I would like to introduce our conveners, Dr. Anujit Paul, sir. So he's currently working as a consultant for cataract and vitreoretina services at BBI Foundation, Kolkata. He has been recipient of so many awards and has numerous publications from his end. Yeah. So the next is Dr. Rolika Bansal. So she is also working as a consultant in ocular oncology and oculoplasty at Mahatma Gandhi Medical College and Hospital, Jaipur, Rajasthan. Again, a recipient of numerous awards and also has done numerous publications and research projects. And this man definitely needs no introduction, Dr. Prasanna, sir. So the current joint secretary for the YOSI, and he's also working as a consultant and he's currently the research director and glaucoma head at Mahatma Eye Hospital, Trichy, India. So I welcome you all.
So it's my huge privilege to introduce the judges for today's session. Dr. Marian Polly ma'am, she's a senior consultant and head of department at Giridhar Eye Institute, Kochi, Kerala. Dr. Feroz PM ma'am, she is the director and founder at Horace Specialty Eye Care, Bangalore. Dr. Sharis Ann Sanche, she is a specialist in orbit lacrimal ophthalmic plasty and reconstructive surgery, as well as comprehensive ophthalmology in the Department of Ophthalmology and Visual Sciences at University of Philippines. So I welcome all the judges, and I would like to request Dr. Rolika ma'am to introduce the panelists.
Yes, we have a wonderful panel. We have Dr. Sahil Agarwal from RP Center, AIMS, New Delhi, at the Oculoplasty and Ocular Oncology Services, and we have Dr. Adit Gupta from Mumbai, and he's oculoplastics and reconstructive surgeon, and he has his own practice over there, and Dr. Akriti Desai from Shantilal Sangvi Eye Institute, Mumbai, and we have Dr. Aditi Mehta Grewal, who is a consultant, Grewal Eye Institute, Chandigarh, India. So welcome everybody. And also the keynote speaker, Prasanna, would you like to introduce our keynote speaker?
Yes, Rolika. I would like to introduce Dr. Shruti Nishant ma'am from an MNI hospital, who is going to talk about an innovator molecule today. We welcome you, ma'am. Over to you, Rolika.
Yes, I would just request, I know that it's a long session coming up, but I don't think anything begins without blessing. So short comments from Dr. Grover sir, Dr. Usha ma'am, and Dr. Kasturi ma'am. So over to you, Grover sir. Would you like to say something as blessing, and then we go ahead with our session?
Thank you, Rolika. I think it's a great initiative, and it is heartening to see how much enthusiasm there is in oculoplastics. From the days of oculoplastics being a beginning of by led by just 9 people in the country when we started the Oculoplasty Association of India to a gigantic organization now with very active participation in the specialty is extremely heartening, and it is great that YOSI is taking it forward. All the best.
Thank you, sir. Usha ma'am, would you
Yeah.
like to say something?
Wishing you all the best. I think it's so heartening to see so many youngsters in the field. And I think the future is very promising. All the very best to every participant and all those who are here.
Thank you, ma'am. Kasturi ma'am, over to you.
Yeah, I should congratulate all the young, the YOSI, ophthalmologists of India. I really appreciate all the presentations that I see, like presented by each one of you. What I really appreciate is the clarity of thoughts that I see in each one of you and the confidence in delivery or organizing such sessions. So best wishes, I'm sure it will be an amazing one. And we look forward to hearing all the different speakers, their presentation. And I congratulate all of you. I'm sure all will be the winners. Thank you.
Thank you so much, ma'am. We've tried so hard to keep it very short and sweet so that everybody is able to present their part. And we had such great, entries as your pearls. And I'm really glad that we have all of you join in. And it was Dr. Nupur's stand that we should have all the your pearls included. And here we are with all of you. And Nilesh, we will add your comments and then we will move on with our session today. So over to you, Dr. Nilesh, Secretary.
Thank you, Rolika. So I would just like to echo what Puneet sir was saying. And first of all thank you, Ashok sir, Usha ma'am, and Kasturi ma'am for being here and blessing us always. Like sir and ma'am, they have been a constant support for YOSI, and we are very grateful for that. And what Puneet sir was saying, when I joined as joint secretary, we had I think half a session for oculoplasty and oncology. And then when Puneet sir last year was saying that he wants 2 sessions, one for oncology and separately and oculoplasty separately, I was like, really, do you have so much stuff? Because I am like completely novice for oncology and oculoplasty. But to my surprise, the free papers and the videos were more like the most submissions were from oculoplasty and oncology, and that was very heartening to see in the last year YOSICon. And this year also, we are sure with the turn up that is going to happen. This is again going to be the star subspecialty, and kudos to the entire oculoplasty group. I think the next gen of this subspecialty is leading YOSI, and I'm very happy to see this subspecialty grow at this pace. So all the best for today's webinar, and looking forward to it. Thank you.
Thank you so much.
Rolika, just adding on to it, I would like to invite all oculoplasty team as well as all the seniors with your blessings to YOSICon as well. The International YOSICon this year is happening on July 10, 11, 12, Aero City, Pullman. So would like to invite you all. Back to you, Rolika.
Yeah. No, absolutely. This is really great to see, and I think it was given. The participants were given maximum 4 or 5 days for coming up with the Yo Pearls, and it's amazing how everybody has worked hard. So over to the moderators for the session. Over to you, Yugandhara. So just to have a flow, Dr. Tanya Roy, we will be keeping everybody back to back. So please try to look out for your name ahead of time so that we keep everything tight. And we will have a timer for Dr. Tanya Roy starting for 1 minute. It will show up on my screen. I'll just start that off. Otherwise, Tanveer, it's
So
over to you.
Rolika, when she starts speaking, when we project her pearl, then you start the timer. Okay?
Sure.
Yeah. Yugandhara, over to you. Yes. Yugandhara, are you there?
Yeah. So we welcome the very first participant, Dr. Tanya Roy. You can start with your presentation, Dr. Tanya.
This pearl highlights the ocular destructive procedures at a glance. It includes enucleation, which is a surgical removal of the entire globe from the orbit. Indications being retinoblastoma, painful blind eye, sympathetic ophthalmia. Rehabilitation is orbital implants and prosthesis. Benefits, it is safest in intraocular malignancy. Evisceration is a surgical removal of the intraocular components, leaving the shell and extraocular muscles intact, mainly for endophthalmitis and panophthalmitis. Benefits, it gives the best cosmesis and prosthetic motility. And exenteration is surgical removal of the entire contents or vital contents, which may include muscle, fat, with or without the eyelids. Indications are mainly invasive tumors and mucormycosis, recurrent aggressive orbital and lid tumors. The rehabilitation is spectacle mounted acrylic prosthesis, and the benefit of it is mainly a life-saving more than a cosmesis procedure. Thank you very much.
So that was, thank you, Dr. Tanya. And it was a very short and crisp presentation. So I would request Dr. Kasturi ma'am to kindly comment, or if any questions she wants to ask.
A very nice presentation. She has included everything in details, but one thing I think she must have missed. I think exentation, sometimes it is not that always we go ahead with prosthesis. Sometimes we just cover the whole socket with a flap. So that is also one of the modality of treatment. Otherwise, everything she had included very well.
Thank you, ma'am. I'll keep that in mind, ma'am.
So next we have on board is Dr. Isha Agrawal. She is a consultant in cataract and oculoplasty at Drishti Netralaya. So over to you, Dr. Isha. All the very best.
Dr. Isha?
Dr. Isha,
I think she's muted.
can you unmute yourself, Dr. Isha?
Yes. A very good evening to respected judges, panelists, and moderators. So, my category is in eyelid, and the pearl I would like to share today is the eyelid is a living hinge, and we must always and always test the intraoperative blink. So, one of the most underrated pearl in oculoplastic is eyelid repair is a balance between anatomy, tension, and the blink. And we must not treat eyelid tissue as a static tissue, as it is a living hinge. And if we reconstruct thinking only of closure, we may succeed surgically but fail functionally. So before we put our first suture in any surgery such as ptosis, blepharoplasty, we must always ask three questions. Where is the lid margin vector? What will happen during blink and not at rest? And are we restoring the lamella or merely filling a defect? So a perfect eyelid surgery respects the lamellar anatomy. The anterior lamella must glide over the posterior lamella. When this harmony is lost, patients don't only complain immediately, but they blink may complain every day. So the tension that we place must be redirected away from the lid margin. Thank you.
Thank you, Dr. Isha. It was a good presentation. Now I request Dr. Polly to comment on the same. Dr. Marian Polly. Ma'am.
So one thing which I wanted to tell is how many sutures will you take?
Ma'am, for the primary sutures?
Lid margin.
Ma'am, we take 3 cardinal sutures, and
which is the most important suture?
Is the central suture, ma'am.
It goes through?
Pardon, ma'am?
It goes through which structure? Which anatomical region?
Ma'am, it goes through the the superior edge of the tarsus, and we take a bite through the LPS. And if we are forming a lid crease, first we take this cardinal suture, and
so the lid margin, which is the cardinal suture to get the perfect alignment.
Ma'am, the LPS and the superior edge of the tarsus.
Lid margin, if it's a cut through.
Lid margin. See, if you want,
Vertical, if it's a vertical.
Then go through the Meibomian glands so that tarsus will be well aligned and we get a perfect alignment of the lid margin. Anyway, good presentation and good pearl. Thank you.
So next we have in line is Dr. Sakshi Raj. She is currently a resident at Civil Hospital, Palwal Hospital. So over to you, Dr. Sakshi. All the very best.
Good evening, everyone. My topic for today is ocular examination of ptosis. So in this, first we need to differentiate ptosis with pseudoptosis. After that, we need to measure several distances, such as the palpebral fissure height. After that, we will be measuring MRD1, which is the distance from the corneal right reflex to the upper lid margin in primary gaze. Then MRD2, which is the distance between the corneal right reflex to the lower lid margin After this, we will be measuring the LPS muscle action, which can be done through different ways, such as the Burki's method, the MLD, which is the marginal limbal distance. After that, the MRD3, which is the marginal reflex distance 3. Then we will be measuring the looking for the Bell's phenomena as well as the jaw winking phenomena. Bell's phenomena is important so that we can rule out the any chances of post-operative exposure keratopathy. After that, we will be examination of pupil is required so that we can rule out any Horner syndrome or the third nerve palsy. Measured basically on all these methods, we can also differentiate on the degree of ptosis. Thank you.
Thank you, Dr. Sakshi. Now I request Dr. Feroz ma'am to kindly comment on the same or ask any questions from her.
Yeah. Hi, Sakshi. I understand you're a resident and you have done a wonderful job here. Now, one question for you. Is extraocular motility important when you do an ocular examination of ptosis?
Yes, ma'am, it is important because we can rule out strabismus also through these things. So that if the ptosis is there and strabismus is also there, we will be first we will be doing the treatment for strabismus first and then ptosis.
Okay, so what are the association of motility limitation associated with ptosis? Second question, and I'm done.
Motility limitation. Ma'am, LPS muscle action can be reduced because of this so that the patient will not be having any elevation factor.
Elevation can be affected in a congenital ptosis, right?
Congenital. Yes,
Yeah,
ma'am.
by
And yes, ma'am. And superior rectus muscle also can be affected because since in congenital ptosis, embryologically development, the LPS muscle lies in conjunction with the superior rectus. That's why, ma'am.
excellent. So
Yes,
in an ocular examination of ptosis, you have
Yes,
to
ma'am.
always mention extraocular motility. Very
Okay, ma'am.
important. Okay.
Okay. Okay.
Excellent.
Thank you, ma'am.
Yeah.
Thank you.
Thank you.
Just to
Thank you, ma'am.
remind the judges, I have refreshed the spreadsheets once again. Could you please check if you're able to add the marks? I got the inputs from Dr. Marian and Dr.
We're not
Chet.
able to add.
Ma'am, just refresh the page once and it will be fine, ma'am.
Ma'am, so when you're just opening directly, ma'am, it is only view only. So
Yeah.
what you need to do is like you have to download it. So there is, when you go to the file,
Yeah, there is a download thing.
correct. You download it, ma'am, and put it separately into your desktop or wherever, and then only you're able to enter.
Oh.
Otherwise, it's only view only.
No,
All right.
ma'am, the
So-
view only segment has been changed.
Then it's fine.
Yeah,
Because
now
when
you
I
can
opened
enter
it, it
it.
was only view only,
Yeah,
so
yeah.
I had to download it.
You
Fine.
can refresh it.
I've requested for an edit access.
Yes, ma'am. Lippy
And
has received it. Actually, she's sharing there. So I've helped her out. It's
no,
now
I'm still not
working.
able to. I'm not still able to enter.
Okay,
No,
ma'am.
Rolika-
Send me the marks. I'll fill it in for you.
Right.
Rolika, we don't need to give the marks, no, only the judges, right?
Ma'am, for you, sorry, ma'am.
We don't need to give the marks, only the judges, right? Me,
Sure,
Dr.
ma'am.
judges.
Yes,
Yeah.
ma'am.
Then
Yes,
Usha, you don't have to worry.
Ma'am, we kept it for Ashok sir and Usha ma'am also because you had mentioned that you'll be leaving early.
Yeah,
So
I'll be
yeah,
leaving.
yes, ma'am. So we kept it for the chairs as well.
Rolika, can you just give us the pattern, the distribution, how the marking is to be done?
It's 25 marks for clinical relevance, 25
Okay.
marks for strength of pearl, 25
Okay.
marks for overall impact, and
Okay.
25 marks for adherence to time. Becomes total of 100. And you can send me the marks and I can add it for you on the spreadsheet.
We'll give you a nice photo of how we mark.
Perfect,
Okay.
sir.
So first was clinical.
Clinical
Relevance.
strength of the pearl, overall impact, adherence to time, right?
Yes.
That's on the
Okay.
spreadsheet, but we're not able to.
Okay, thank you.
Okay. Yes, you can.
Rolika, otherwise, can you share the offline version on the group and
I'll
from
do
there
that.
they can.
Yeah.
I know, yeah.
I'll
So
do
we can
that.
take the screenshots. They can share the screenshots later on also. That's okay. If the
Sure.
live thing is not working, that's not a problem.
So the download really worked. So anyways.
Yes. Yes.
Okay, I will send the
Now-
download version as well
I
to
think you
everyone.
should.
Yes, yes.
Thanks.
Just share that. So that will make it simple.
For me, all perfect.
Okay, so moving forward, we have our Next participant, Dr. Shazia RB. She is currently working as a consultant at Lotus Eye Hospital, Salem. So over to you, Dr. Shazia.
Good afternoon, ma'am. My pearl for presentation today is orbitotomy incisions. So the various approaches are to the superior root, the sub-row incision, which is the Benedict incision. Then we have the upper lid crease incision. And supromedial aspect, we have the lid split incision, the Brown-Smith incision. And medially, we have the transcutaneous, the Lynch incision, the frontoethmoidal incision. That's through the cutaneous root. And we have the Seagull incision. Coming to the conjunctival aspect, the transconjunctival incision, which is the limbal base incision, and transcanalicular incision, which is the Goldberg incision. Inferiorly, we have the lower lid subciliary incision, inferior phoneal transconjunctival incision. And to the supratemporal root, we have the stellarterite incision, and we have the extension of the upper lid crease incision, and then we have the lateral canthal incision, which is the Berkey's-Rees incision. Thank you.
Okay, thank you, Dr. Shazia. So now I request Dr. Shariz ma'am to kindly give comments on the same. Dr.
Hi,
Shariz and ma'am.
yes, good evening from the Philippines. First of all, I would like to thank Dr. Nupur most especially for this invitation. I can't believe I'm on the same webinar with the rock stars of AP Soppers and YOSI. So thank you for this invitation. For this presentation of Dr. Shazia, did I pronounce it correctly?
Yes, ma'am.
Yeah. Thank you very much for this presentation. Actually, I was looking for something like this, wherein for the presentation itself, it's very clear. The visual aid that you use, the picture matches every point that you said, like they match the auditory cues match the visual cues perfectly. So congratulations on that. And I saw that you are a comprehensive ophthalmologist, but I know that you have a special interest in oculoplastics, and this is a very detailed report about your incisions in orbitotomy. Thank you for your presentation.
Thank you, ma'am.
Thank you, ma'am. Thank you, Dr. Shazia. So next we have is Dr. Reema Seeth. She is currently a fellow in orbit and oculoplasty at Narayan Nethralaya. So Dr. Reema, you can go ahead with the presentation.
So good evening, everyone. So the title of my pearl is Clinical Tetrad of Lacrimal Canaliculitis. Do not miss the grid. So it is an uncommon condition that is commonly misdiagnosed as blepharoconjunctivitis, chalazion, and nasolacrimal duct obstruction. The key diagnostic pearl in this clinical tetrad is, first, the pouting punctum, expressible thick paste-like discharge, gritty concretion, and characteristic yellow sulfur granules, which suggestive of actinomycetes canaliculitis. So in chronic, unilateral epiphora with discharge always press the punctum. So this slide highlights a key oculoplasty pearl on lacrimal canaliculitis, emphasizing the clinical tetrad and characteristic sulfur granules to improve early diagnosis and prevent mismanagement. Thank you.
Thank you, Dr. Reema. Now I request Dr. Sahil sir to kindly comment or ask her any questions related to this.
Hi, Reema. I think you have covered the basics very well. The images that you have put up and the details of it is very clear. What would you do to treat such a canaliculitis? What is the standard of management for all these cases of canaliculitis?
So in these conditions, if a patient has thick concretions like of discharge, so it won't come out from the small punctum. So in these conditions, we can do canaliculotomy with syringing with antibiotics.
Right, great. I mean, so that is what I read with the discharge plus a pouting punctum should always think canaliculitis, and yes, opening up it is the best way out. Thank you so much, Reema.
Yeah,
Great job.
Yeah, so she has one more presentation, Dr. Reema. Yeah, you can go ahead.
Yeah. So the title of my second presentation is seborrheic keratosis, which looks alarming, but it behaves in a benign manner. So seborrheic keratosis often appears worrying because of its pigmented, irregular, and warty surface. So there are three classical clues with which we can diagnose. First, a typical stuck-on appearance as if the lesion is pasted on the skin. Second, An ugly surface with polite behavior, but a greasy, varicose texture, often with keratin plaques. And the third is usually an old, long-standing lesion in an elderly patient, showing slow, unhurried growth. So lesion may shout visually, but it whispers clinically, and that contrast is the key diagnostic hint for seborrheic keratosis. So whenever you see a lesion that looks alarming but behaves benign, you can always think of seborrheic keratosis. Thank you.
Yeah, it was a good presentation, Dr. Reema. Thank you. Now I would request Dr. Ashok Grover sir to kindly ask her any questions or kindly give his comments or opinions regarding the same.
I've enjoyed Reema's presentations because she's really understood what is meant by a pearl. And she has really taken a very narrow field and pointed out what is the clinical pearl that is important in diagnosing that condition or in differentiating that condition from others. I think that I appreciate the most. And I think the key is to think of a condition as benign versus malignant, because therein lies the key to what you are going to plan to do. And I think she's given some very nice points on how to identify seborrheic keratosis particularly, but the key lies to identify those features which indicate malignancy in an eyelid lesion. And I think that will be a very important thing which all of us need to know.
Thank you so much, sir. That was really insightful. So now I would like to invite Dr. Tanveer to introduce the rest of the participants.
Thank you, Dr. Ikandra. Next participant we have with us is Dr. Simran Khosla. She is MBBS MS Ophthalmology and currently working as SR in SNMC Jodhpur. Over to you, Dr. Simran.
Okay. Good evening, everyone. So today the title of my presentation is A Stitch That Cries. As the name suggests, mainly I want to focus upon that whenever we are repairing a lower lid or the lid, we just don't respect the canaliculus. We forget about the canaliculus. We get so much immersed in just repairing the lid. So this is basically focusing upon that. In emergencies, whenever a patient comes to us, generally we are unable to find a canalicular stent to keep the patency of the canaliculus. So during my residency, I have found this thing that you can put on a pediatric cannula in the punctum and then suture the pericanalicular part and keep keep the catheter inside the canaliculus for 7 days. And on when the patient comes to you after 7 days, you can just remove the catheter and remove the sutures, and the patency of the canaliculus is maintained in that thing. So this is so whenever you repair a lower lid, just respect the canaliculus. That's the pearl I want to focus upon. Thank you.
Thank you, Dr. Simran. Now I would request Dr. Akriti to please comment upon the same.
Thank you, Simran. I like your title, A Stitch That Cries. And what you've pointed is very true. I understand you practice as a comprehensive ophthalmologist and might have come across this during your residency days. And it's quite important to not miss the canaliculus, be it the lower or the upper canaliculus. I have also seen this IV catheter vein flon being used, maybe 24 gauge. But my question to you would be, what is the other option that might be a little more expensive, but does not cause any foreign body sensation and it's more smooth, fits better in the canaliculus?
Ma'am, silicone canalicular stents are available that can be kept in place, but generally in emergency we are unable to find them. So this is a temporary measure that we can do.
That's agreed. But do you know the name of what is the stent that can be used?
Ma'am, actually, I'm not remembering the name of the stent right now. Not
No
remembering.
problem. It's called a Monoka or mini Monoka, which can be
Monoka,
fixed
mini
in place.
Monoka, yeah. Yeah.
Thank you. Very important.
Thank you, ma'am.
So thank you, Dr. Akriti and Simran. Next in line, we have Dr. Samita HR. She is a senior consultant at Netradhama Super Speciality Eye Hospital. Over to you, Dr. Samita.
Thank you. So basically, I have made this slide as we used to send out yolk pearls. Am I audible?
Yes, yes.
Yes. So we used to send out
Yeah, we are
yolk
audible.
pearls in on WhatsApp. So I have made this slide in a similar context. So basically, I wanted to highlight this Gopal Krishna classification of grading of contracted socket. We do have latest grading classifications, especially Tawfiq, who gave it in 2009. But I still find this Krishna class.
Ma'am, your voice is not.
Samita, we've lost your audio. Okay, so I think in the interest of time, let's move on
And grade
to
4. Hello? Hello,
Yeah,
can you hear me?
Samita, can you start over again? We lost your audio in between.
Okay, right. Am I audible now?
Yes.
Yeah. So I still find this Gopal Krishna classification of grading a very simple and easy thing to follow, though we have newer classifications. And his grade was very simple. Grade 1 was a shallow lower phonics or a shelving of lower phonics. Grade 2, loss of both upper and lower phonics. Grade 3, loss of all the fornices and loss of volume. Grade 4, there is also reduction in dimensions of the vertical and horizontal palpebral apertures. And grade 5 was for recurrence of contracture after trial of reconstruction. So this is easier for us to follow because grade 1 we can do a phonics formation sutures. Grade 2 would probably require a mucous membrane graft for the conjunctival repair. And grade 3 would also probably require a dermis fat graft or volume reconstruction by other methods. And grade 4 would require combination surgeries or multiple surgeries. So I find this very useful for me while treating the patients. Thank you.
Thank you, Dr. Samita. Now I would like Dr. Aditi Mehta to please comment upon the pearl.
I think Samita is a very dear colleague, and thank you to the
I
YOSI panel for
agree.
having me as a panel for this. So, of course, we always do go back to the Krishna classification. So, rather than a question, I'd just ask Samita if she can just elaborate for the other participants also. How do we measure the fornicial depth clinically? It will be a useful tip for all of them as well.
Yeah, so one way I measure the fornicial depth is, of course, I look at it clinically if I'm able to retract the lower lid and see till the fornix. That is first step. If you're not at all able to retract or if there is enrolling of the lid margin, then that automatically tells us that there is a shallow fornix. And one very unconventional way of how I measure is I also probably compare it with the other side, and I use a Shermer strip to measure from the fornix till the lid margin, and I compare it on both sides, and that gives me whether it is shallow or not. Like very mild shallowing probably we can pick up by this method. More severe shallowing would be clinically evident. So
Yes, exactly. So the Shermer strip, especially for the inferior fornix, because that is the one which will hold your prosthesis. So that's a very good way of objectively measuring the shallowing, and excellent summary in Pearl in 1 minute.
thank you so much, Aditi.
So we have another pearl submitted by Dr. Samita. Ma'am, you can please present your next pearl.
Yeah, so my next pearl is on signs of lacrimal gland cysticercosis. So I have come up with this particular pearl because I've got many patients, almost 4 patients till now, who have been treated as an orbital cellulitis primarily, given a course of IV antibiotics or oral antibiotics, no response, and then the patient comes for a second opinion. So if we see any patient who is presenting as an orbital cellulitis but is also having an S-shaped ptosis, and there is not much of inflammation throughout the eye, like the inflammation is localized to more of the temporal part of the eye, and there is a diplopia associated, ocular motility restriction especially on abduction, and there is a dacryoadenitis on CT particularly, and also indentation of the globe superotemporally as seen on CT. And all these are classical signs of a lacrimal gland cysticercosis, especially indentation of the globe. So sometimes we may appreciate a scolex in certain cuts, but sometimes the CT does not give us a very specific scolex or thing towards cysticercosis. But the presence of all these other factors should give us a clue that it could be lacrimal gland cysticercosis, especially when it is not responding to antibiotics, and immediately start anti-helminthic drugs and oral steroids, and the patient will recover beautifully. Thank you.
Thank you, Dr. Samita. Dr. Aditi? kindly ask any questions.
I think, again, a very relevant clinical pearl. So, along with the indentation of globe and, of course, the presence of scolex, I probably would want to add that there is the bony region of the orbit is absolutely intact, because
Yes.
a similar differential could come in a lacrimal gland tumor, but that would have some kind of a bony erosion. But cysticercosis will not have that. And definitely steroids before starting the albendazole, a 48-hour cover. Plus, I would also like to mention that we should do a CT scan for of the head also to rule
Head,
out
yes, brain.
neurocysticercosis in the same
Yes, yes,
situation.
absolutely. And I think I want to add one more thing is what I have observed in such cases, there is more of a dacryoadenitis and local inflammation and not much of orbital fat stranding as we would see if it was a generalized orbital cellulitis. So looking carefully for that can also give us a clue.
Excellent pearl again.
Thank you. Thank you so much, Adit. Thanks.
Thank you, Dr. Samita and Dr. Aditi. Next, we have in line Dr. Kaveri Birla. She's a postgraduate resident at Lady Hardinge Medical College, Delhi. Over to you, Dr. Kaveri.
Good evening, everyone. Am I audible?
Yes, ma'am, you're audible.
Yeah, so my pearl is the category was lacrimal. My pearl emphasizes why a simple pre-operative evaluation of the ocular surface is essential before a couple of oculoplastic surgeries like blepharoplasty, ptosis, ectropion, or entropion correction, especially in patients with dry eye symptoms or similar risk factors. In such cases, conservative skin incision and ocular surface optimization helps reduce post-operative dry eye complications. The pearl emphasizes the three layers of the tear film, the lipid, aqueous, and the mucus layer, and the different parts that they are secreted from. The lipid layer is secreted from the meibomian glands, the glands of Zeiss and Moll. The aqueous from the lacrimal gland and the accessory lacrimal glands, and the mucus from the goblet cells and the glands of Mons. So this is my pearl. It's about how a pre-operative evaluation is essential in such surgeries.
Thank you, Dr. Kaveri. Now, I would request Dr. Adit Gupta to please kindly comment on the same.
Hi, Kaveri. That's a very important pearl that you have pointed out. You cannot emphasize enough, especially for patients undergoing ptosis or blepharoplasty surgeries, to have an evaluation of the lacrimal status. And lacrimal status doesn't just, usually for the lacrimal system, we always look at sac syringing, or we want to look from that perspective, especially for cataract surgeries. But for any surgery which involves the eyelid or where you're sort of playing around with the eyelid, it's so important to see that they don't have any pre-existing abnormality. And if at all there is, then you need to correct it and then do the surgery, or at least prime the patient about it. So I think this is a very important pearl that you have brought forward.
Thank you, sir.
Thank you, Dr. Kaveri, Dr. Adit. Now, I would like to hand over to Dr. Lipi to please continue with the remaining pearls.
We can have a comment from Dr. Usha ma'am also regarding this pearl. Ma'am.
It's an excellent pearl. Actually, just only to add a few things, you need to look at what low lipids would do. It will cause a rapid evaporation. If there's poor mucin, there will be spotty coverage. All these things you have to keep in mind. And the other thing is the tear breakup time a little bit, but I think 1 minute is too short a time to talk about all of those things. So I think whatever you covered is really good, Dr. Kaveri.
Thank you, ma'am.
And a lot of times this is a forgotten pearl.
Thank you, ma'am.
Thank you, ma'am.
So our next speaker is Dr. Ranu Sharma, but she could not join us today. Her pearl was cutaneous horn of the eyelid, but in view of time, we'll skip this pearl. So our next speaker is Dr. Neha Bhose. She's a consultant oculoplasty at Sushila Netralaya. Over to you, Dr. Neha.
Good evening, everyone. So often in the study of oculoplasty and the orbit, what we see clinically is just the tip of the iceberg, and often there is more going on than meets the eye. So an apparently small capillary hemangioma in an infant on the ocular surface may have a very significant orbital component. And imaging is orbital imaging is key in these cases, especially if the posterior border of the lesion cannot be appreciated clinically. This is important because the extent and the size of the lesion as seen on imaging is what determines the final management of these conditions. Thank you.
Thank you. I would like to request Dr. Sharice ma'am if she's here.
Yeah.
Yeah.
Hi, good evening. I would like to congratulate Dr. Niha for this presentation. First of all, your presentation was concise and direct to the point. Capillary hemangioma is very common, even here in the Philippines, and it's really, I think it's very relevant because it can get disfiguring as the during its proliferative phase. So, thank you for this presentation.
Thank you, Dr. Sharice.
Thank you. So our next speaker is Dr. Resham Bhatia. She's a junior resident at Mahatma Gandhi Medical College, Jaipur. Over to you, Dr. Resham.
Good evening, everyone. Today I'll be presenting on dermoid cyst, a developmental trap. For easy understanding, I have expanded dermoid as D being developmental, congenital choristoma, with having ectodermal elements at sutural sites. It is round to oval, painless, slow-growing mass. M standing for sites occurring in descending order, mostly sutural, that is superotemporal in position, and followed by anterior orbital, followed by deep, interosseous, transorbital, and subsequently conjunctival. O stands for orbital cyst lined by stratified squamous epithelium. Imaging in dermoid cyst, imaging shows hyperintensity cyst on MRI and bony deformity with or without intralesional calcification on CT, where D is the warning symptom, warning sign that do not rupture since it causes severe inflammation. Thank you.
Thank you. I would like to request Dr. Akruti ma'am for her comments and questions.
Akriti ma'am, you're mute, ma'am.
Sorry. That was a very nice, important pearl, and you've made a beautiful mnemonic out of it. So, at covering all points, I would like to ask you, how does you said it has hypo and hyper both on an MRI, but just can you tell me what looks hypo and what looks hyper on MRI in dermoid, if you can share of it?
Yes, ma'am. High fat content looks hyper intense, that is bright.
On okay.
Yes, ma'am. And this is the most characteristic, I guess, not and.
No, that's good enough. You're a junior resident. That's good. On T1 weighted MRI, the fat looks hyper intense and the fluid will look hypo. Whereas on T2, it's the reverse. The fat will look hypo and the fluid will look hyper. But I like how comprehensive your pearl is. Very well done.
Thank you, ma'am.
Thank you. So our next speaker is Dr. Renu Chaudhary. She's a senior resident at Gitanjali Medical College and Hospital, Udaipur. Over to you, Dr. Renu.
Good evening, everyone. So my pearl is lid margin, the surgical GPS. I think this pearl would complement Dr. Isha's pearl. In lid margin surgery, most complications are not from tissue loss, but from wrong plane selection. The plane is identified by the gray line. The gray line represents the junction between the anterior and posterior lamella at the lid margin. Anterior to it lies the skin, orbicularis oculi muscle, and lash follicles. Posterior to it lies the tarsus, meibomian gland orifice, mucocutaneous junction, and conjunctiva. In lid splitting procedures, margin repair and reconstruction, dissection along the gray line separates lamella safely. During closure, precise gray line realignment restores normal margin contour and eyelash orientation. Misalignment shows up notching and patient pay with lash misdirection, ocular surface irritation, and keratinization related problems. So split there, align there, and the lid margin behaves. Thank you.
Thank you, Dr. Renu. I request Dr. Adit Gupta, sir, for his comments and questions.
Thank you, Dr. Renu, for this wonderful remembrance about the gray line. I like this pearl, but the gray line, I would label it as the surgical as well as a medical GPS. It's just not surgical, but also a diagnostic tool. So if I may ask you one question, what is the most common cause of mucocutaneous junction migration? If you can answer that, then you'll know why it is also a medical GPS.
Some most common condition,
Yeah, most common condition that you would see commonly in the clinic where the mucocutaneous junction would migrate.
Chalazion.
Chalazion is one, but more commonly you'll see it in severe mebomitis or
Sir,
severe
yes,
dry
sir.
eyes.
Yes, sir.
Yeah, so it is also a medical GPS in addition to a surgical GPS, as you have correctly pointed out. Thank you so much.
Thank you, sir.
So our next poll is also by Dr. Renu. Dr. Renu, you
Okay.
can. Yeah.
This poll is about painless progressive proptosis. In orbital disease, the progression and pain profile guide the urgency. Painful acute proptosis most often suggests inflammation or infection. In contrast, painless progressive proptosis must be assumed neoplastic until proven otherwise. These patients present with the silent orbit, which stands for slowly progressive, insidious onset, little or no pain, exophthalmos, no inflammatory signs such as tenderness or warmth, and tissue diagnosis required. The silent orbit is not a description, it is a call to act early with imaging and biopsy before delay advances the disease. So, in orbital practice, remember the rule pain often reassures, silence should not. Thank you.
Thank you. And I would like to request Dr. Ashok Grover, sir, for his comments.
Thank you. It is a nice pearl, but yes, silent orbit need not necessarily be alarming. There can be benign conditions which may also progress silently. And in fact, one of the commonest entities is the low flow venous abnormality or the so-called cavernous hemangioma, which is one of the commoner tumors. Similarly, the schwannomas and several other benign lesions may also be silent and slowly progressive. Yes, pain is an alarming thing, which makes sure that the patient presents to us early, and we must think of inflammations as well as some of the conditions which involve nerves or which are infiltrative. So yes, it's a very useful pearl, but to be taken in the overall context.
Thank you, sir.
Thank you, sir. Also, I would like to ask Dr. Akruti ma'am for any comments and questions.
I completely concur with, of course, Dr. Grover sir has said something very valuable, that uh, even apart from all those conditions, like in inflammatory thyroid eye disease, another condition in which you can have painless progressive proptosis. So the title is a little misleading, but yes, malignancy, since it's more of a severe condition, it should be kept in mind, and it needs to be ruled out systematically.
Sure, ma'am.
Thank you.
Thank you.
Thank you. I would like to hand over to Nupur ma'am.
Thank you, Dr. Lippy. So our next participant is an international participant, Dr. Fan Thi Thao, and she's a resident at Hanoi Medical University. Unfortunately, she said she could not join in person because of some emergency duty. So she sent across her pearl as a 1-minute video. Dr. Lippy, can we play her pearl, please? Yeah.
Hello everyone, I'm Thao from Vietnam. Today I'd like to share how to identify the conjoined facial sheath. As we all know, challenges of eyelid suspension for ptosis with polyp dysfunction include lid lag, lid tenting, post-operative lack of thymus, and extrusion of suspension material. Recently, many studies have focused on CFS because its lifting vector allows better eyelid global opposition. Its elasticity helps reduce post-operative lack of thymus, and its use autologous tissue. However, identifying the CFS remains a challenge for surgeons. The CFS is a common facial layer between the levator superioris and the superior rectus muscle, and there are two simple pearls to identify it. First, using electrocautery for hemostasis keeps the cervical field clean and improve exposure.
Lippy, the video has got paused, I think.
And the second, expose the tarsal plate. Transit the levator muscle and then dissect posteriorly behind the levator and move superiorly towards the fornix. And when you encounter a firm, elastic gray structure located about 2 to 8 millimeters above the fornix, that's a CFS. Thank you for listening.
So I think that was a very nice pearl which has been shared by Dr. Fan. So I'll request Dr. Aditi Mehta Grewal to obviously cannot ask any questions from her, but you can just comment on this pearl. Over to you, Dr. Aditi.
So yes, this is quite relevant because identifying this structure, sometimes we confuse it with the transverse ligament, which is more anterior to this. And if the suspension passes through the anterior transverse ligament in severe ptosis cases, it can lead to a very static eyelid, which will actually not relax, and there'll be severe lag of ophthalmos. So it's important to differentiate and dissect underneath the levator to reach this conjoined facial sheath and then resuspend properly so that we still have a dynamic lid even in severe ptosis cases. If
Thank you,
Dr.
Dr.
Ashok Grover sir could further elaborate on this, and so could Dr. Kasturi, it will be grateful because this is something which is like an advanced pearl, I would say. And if they can tell us a bit more about it.
There's been increasingly greater literature on this as a surgical procedure for cases of severe ptosis, and is a procedure which has been done by a limited number of people. I have no personal experience of doing this procedure, but well, yes, there is enough literature now to back it, and yes, we can all trying it out in some of our cases.
Thank you, sir, for sharing your insights for that pearl. We'll move on to our next participant. So this is Dr. Survi Shalini. She's a consultant, Eye Care Eye Hospital and PG Institute, Noida. So over to you, Dr. Survi, for your pearl presentation. Yeah.
Good evening, everyone. My pearl is on epiblephron. Epiblephron is a condition usually seen in infants of Oriental and Asian race. In this condition, pretarsal orbicularis and skin override the eyelid margin and eyelashes assume vertical position. Sometimes they rub against ocular surface and then become symptomatic. Important differential here is congenital entropion, where the eyelid margin itself rolls over. This condition usually resolves spontaneously, so observation is best for asymptomatic cases. Topical lubricants can be prescribed for mildly symptomatic cases if there is just watering and irritation. If there is a recurrent corneal pathology, surgery can be planned, wherein a thin strip of skin and orbicularis is excised. Thank you.
Thank you, Dr. Survi. That was really crisp and very relevant. So I'll request Dr. Feroz ma'am to comment on this pearl.
Yeah, hi.
Hi, ma'am.
Yeah, hi, Surbi. It's a good pearl that you actually highlighted over here. Something we have to differentiate between, entropion and an epiblepharon, where epiblepharon most of the time is self-resolving. Is there any other way, apart from a surgical correction, that you have learned or read in the literature where you can treat epiblepharon?
We can just pull the eyelid down and tape it down, or just do topical lubricants is most of the time it's sufficient enough.
Okay, so there is a literature which has been published. In fact, Dr. Milind Naik has spoken about it, where you can actually use a filler because it's temporary and it is subsequently resolving, and then you can turn it outside and until the child grows, the cheek fat pad, everything settles down, and then that is one of the things that you can think of.
Thank you very much.
Yeah, excellent. Thank you.
Thank you, Dr. Feroz ma'am. Next, Dr. Surbi, you have one more poll, so over to you. Can we have the timer for Dr. Surbi, Rolika? Yeah.
Cysticercosis is an infection caused by larval form of poke tapeworm. It can have varied presentation in eye and adnexa. Recent onset diplopia and restriction of extraocular muscle could be due to cysticercosis in extraocular muscle in endemic regions. It may also present as conjunctival chemosis, congestion, pain in ocular movement, proptosis, ptosis, and occasionally orbital cellulitis. This is readily diagnosed and monitored on ultrasound B scan, where a cystic lesion is seen in extraocular muscle with hyperechoic center corresponding to scolex. This is managed medically with oral albendazole and oral steroids in a tapering dose. Thank you very much.
Thank you, Dr. Surbi, for again a very wonderful, crisp presentation. So I'll request Dr. Marin Polly ma'am to please comment or ask any questions if she would love to. Over to you, Dr. Marin.
Thank you, Dr. Surbi. It's an excellent pearl. You have summarized everything. My only question is, if it happens in the levator muscle, how the patient will present?
10 minutes. Can I call you in 10 minutes? I'm in the middle of a webinar. Yeah.
Dr. Surbi, if it
Yes, I had a patient who presented with superior rectus and LPS complex. So he presented with eyelid swelling and ptosis.
Yeah.
Unfortunately, this patient did not take the treatment, and then he presented with the orbital cellulitis when his cyst ruptured, and then was managed medically.
Yeah, then you have correctly mentioned oral albendazole 15 milligram per kilogram. How long will you continue treatment?
Yes, oral albendazole, we usually give it for 4 to 6 weeks. And steroid is given in a high dose, 1 to 1.5 milligram per kg, with a tapering dose, tapering 10 milligram every week.
Excellent. Very good. Thank you.
Thank you.
Thank you, Dr. Surbi and Dr. Marin. We have our next presenter, Dr. Varshika Patel. So she's a first-year oculoplasty at Sadhguru Chikitsalaya, Chitrakoot. So over to you, Dr. Varshika, for your poll. Can we have the timer for Dr. Varshika, please? Yeah, Varshika?
I'm going to present a case in which an infant presented to our clinic with a painless progressive swelling of eyelid, showing in the first image, and clinical and imaging on MRI also the patient was the reporting was iso intense swelling was there, and we made a diagnosis of hemangioma and treated by that, but the patient was not responding to propranolol, and then to avoid amblyopia, we went for excision biopsy of the patient, and biopsy showed us xanthogranuloma. So I would like to throw light that xanthogranuloma is a rare entity in childhood, and most commonly we make diagnosis of hemangioma, and patient was treated not treated correctly, and when clinical and imaging deceives, then histopathology is finally showing us the correct diagnosis.
Thank you, Dr. Varshika, for that very, very interesting case presentation as a pearl. So I'll request Dr. Feroz ma'am to give her comments or ask any questions. Over to you, Dr. Feroz.
Yeah. Varshika, excellent. Although, juvenile xanthogranuloma is pretty rare, in the orbit. Excellent presentation. Thanks for bringing this out. Now, is there any other systemic association that which is dangerous with juvenile xanthogranuloma that you would want to evaluate the child?
Ma'am, usually juvenile xanthogranuloma is associated with neurofibromatosis as well, and type 1. And other visceral organs like pericardium, lungs, and liver are also involved.
Yeah. Yes. So neurofibromatosis is one of the most common systemic association, but rarely it can be associated with CML as well. They can be associated with myeloid leukemia.
Yes, ma'am. Juvenile leukemia.
Yeah, right. So you should always do a peripheral blood smear and a blood evaluation in these children. It is a rare association, but it's a very dangerous association. Thank you so much for highlighting this, although this being a very, very rare clinical scenario. Excellent. Thank you.
Thank you. Thank you.
Thank you, Dr. Varshika and Dr. Feroz. Can we have the next pearl, next presenter, Lipi? Yeah. So this is Dr. Mohammad Afzal. This is the last but not the least pearl presentation of the day, and he's a resident at Army Hospital Research and Referral at New Delhi. So over to you, Dr. Afzal, for presenting your pearl. Can we have the timer for Dr. Afzal, please? Yeah.
Good evening, ma'am. My pearl is on mucous membrane graft in Stevens-Johnson syndrome. A mucous membrane graft is a free graft of non-keratinized oral mucosa, usually taken from the inner lower lip or buccal mucosa, and is transplanted to the ocular surface or eyelid to replace scarred or keratinized tissue. This slide demonstrates the role and outcomes of mucous membrane graft in a patient with SJS suffering from severe dry eye. This pre-op image is showing severely dry keratinized ocular surface typical of end-stage SJS. In SJS, there is a cicatrizing inflammation which leads to lid margin keratinization, symblepharon formation, and constant mechanical trauma to the cornea, causing pain and vision loss. Intraoperatively, keratinized conjunctiva and lid margin epithelium were excised and replaced with a healthy oral MMG. At 2 months post-operatively, the ocular surface shows significant improvement with reduced inflammation and improved comfort. Thank you.
Thank you, Dr. Afzal, for that very nice demonstration of mucous membrane graft. So I'll request Dr. Che to please give her comments or ask any questions. Over to you, Dr. Che.
Yeah, thank you very much for this very nice presentation, Dr. Maud Afzal. Uh, uh, I agree that SJS is a very it's quite a miserable condition for our patients, and mucous membrane grafting is a great it's a very promising intervention for our patients, and thank you for emphasizing this. Personally, I don't really do this among my patients. I usually let my external disease colleagues to do it for us, but this is a great reminder for managing SJS. Thank you.
Thank you, Dr. Che. Dr. Usha ma'am, yeah, Dr. Usha ma'am, your comments and any questions that you may have.
Thank you. Excellent. I think it's more of an exam question. And he's highlighted all the points. The bandage contact lens towards the end or a conformer, ring conformer would be great in order to keep the membrane intact, positioned well. So that would be helpful. And the other thing is you can always say that it can be pinker than usual. It has a little difference from the normal conjunctiva. It will be bulkier and those things. And sometimes when you can either use a glue or you can suture it. If the suture is used, then you'll have granulomas. Preferable to use the glues. That's all. But it's a great reminder for us, and I think he's compiled all the points that needs to be written for the examination. Thank you.
Thank you, ma'am. Lippy, can
Can I
we...
put in a word, Nupur?
Yeah, yes, sir. Please, sir. Please, sir. Yes. Yeah.
Thanks to Afzal for keeping the male flag flying in oculoplasty. He was the sole male participant.
I agree, sir. I agree with that. Lippy, can you just stop sharing the screen for a minute? Yeah.
That is wonderful.
So with this, we come to the end of the Pearl presentation competition. But we do have a keynote lecture by Dr. Shruti Nishant. So before we move on to Dr. Shruti's presentation, I think people have started leaving. So we'll take a quick group photograph and also a few comments, closing comments from our judges and panelists. So Rolika, you want to start and just start taking comments one by one from each of them?
Yes,
Yeah.
yes, please. I would first request all the judges to please send their spreadsheets so that I can compile it quickly, real quickly. You can send me a photograph or you can mail me the spreadsheet and I'll put it all together. Thank you so much for taking out your time. And I know that it is very exhausting to listen to everybody, but I love the enthusiasm that everybody had and the encouraging words for the postgraduates. I think it's as postgraduates, sometimes we don't really realize our potential. And I think it's really nice that all of you gave so much encouragement to our postgraduates. Grover sir, some words that you would like to say before we move to our next phase?
Fabulous program. I think this is a great initiative which brings in so much participation, and we get to hear so much useful material, so much to stimulate us to think, so much to make us work better towards our specialty. And the fact that Young Ophthalmologists Society is taking so much initiative in subspecialties is very heartening and shows the progression that has occurred in ophthalmology and in oculoplastics over the years. Fabulous.
Thank you so much, sir. Usha ma'am, over to you.
It's a great mix. It's just not the the oculoplasty people. It's a mix of postgraduates, fellows, and then the accomplished oculoplasty people as well. And it's just a reminder that all of us have a lot to learn. And all of us have taken some takeaways from this session. I think it's very, very important that we all remember that learning never comes to an end. And it's so nice to see the enthusiastic participation. And there's so much potential, and it's so promising.
Thank
And
you so much.
thanks to that one male participant.
Thank you so
Thank you.
much, ma'am.
And of course, I'd have to thank all of you, the organizing team, Nipur and Rolika, for having taken this forward, because this is such a great presentation and very novel. I think it's very important that we keep this in mind. Thank you so much for doing this.
Thank you so much, ma'am.
And
As
it's
I
a pleasure.
said,
Yeah.
yes, ma'am.
I,
As I
I,
said and mentioned that, sorry, Nupur ma'am, go ahead. What do you say?
no, I said it's a pleasure to have Usha ma'am, Ashok sir, and all the judges and panels join us. So it's our pleasure totally to have you encourage us today. Over to you, Radhika, please. Yeah,
Yeah,
please.
I would just say that as postgraduates, we have very little or no exposure to oculoplasty and ocular oncology. And I think I remember from my postgraduate days, the exposure I had, or the person I always followed, was Feroz ma'am. And I think she's smiling because she knows that very well. In COSCON, I think I trolled you rather, like I followed you everywhere and asked you questions. So over to you, ma'am, to please give your comments.
Rolika, I'm so proud of you where you are at this point of time. If at all I have contributed this much, I'm absolutely honored and happy about it. And this initiative, whoever the brainchild is very, very, I mean, it's excellent. So initially, when Rolika said, and I spoke to Dr. Noor, the thought of sitting for 20 cases as a judge, I was telling, you know what, my attention span may not be great for 1.5, 1.5 hours. And then she said, no, ma'am, it's just 1 minute. And then I said, okay, have you done this before? She said, no, this is the first. And then I said, okay, this will be a trial. And this is amazing. Every pearl, and that too finishing in 1 minute, that you guys have really timed up. It was truly a learning for me. It has been truly a revision for me in various aspects. And we have amazing judges, chairperson over here, everyone throwing their insights over it. And the most amazing part about this session is we have a variety of residents, who presented. Then we have senior residents, and then we had consultants. And I am overwhelmingly happy and proud that our residents in India are so smart. One, they had the courage to come and present the cases, and they did extremely well. So our generation is amazing, and I think we should encourage this. And every case is absolutely a learning for us. And I think each conference, should actually imbibe the fact that we should do more of case-based presentations where everyone learns and many gets an opportunity to present. Excellent, Yosi. So proud.
Thank you. Thank you so much, ma'am, for the kind words. And may I request Dr. Marian Polly, ma'am, to please give her kind words as well. Ma'am, it was like you kept everything in real time. My spreadsheet for you is complete. So
Yeah.
thank you, ma'am.
Thank you. Like, I really appreciate YOSI Oculoplasty team for conducting this program. And I mean, the residents are also like, when I have learned so many things in the last 50 to 60 minutes, starting from the basics, even to the advanced, that is including juvenile granuloma. So I actually request the YOSI team to continue this practice so that everybody can learn. Like, from YOSI you will learn, from the seniors, YOSI will learn, like that. It's a kind of mutual interaction and learning. So continue, keep it up, and all the best. Thank you.
So, Nupur, can I say something? It will be nice that you put up, you can name it anything, like, the pearls and plasty. You can actually bring up with the magazine where all cases, one page, where it can be circulated, a PDF, or, as a part of YOSI, you should do that. It's like a small tidbit case report. Yeah. It's nice.
So Dr. Yugandhra and Dr. Tanveer are here. Anujit is leading the BioPearls group. So definitely, ma'am, they'll take this forward and they'll try to release it as a
Yes,
PDF
ma'am,
or
definitely
something.
we'll.
Yes.
Yeah. Thank you so much. Dr. Che, can we request for your comments from across the globe?
Oh my goodness. YOSI has always been the standard of energy in the young ophthalmology world. You are an inspiration to all of us. When I started, when I founded the Philippine Network of Young Ophthalmologists, YOSI was my inspiration. So this project, this activity today, thank you for having me. It's an absolute honor to be on the same webinar as Dr. Fairuz, Dr. Ashok. Thank you. And then uh, I agree with Dr. Fairuz's comment that you should compile all the slides. At first, when I got invited, I was like, okay, so I didn't know what to expect. But then when I saw everything, I think everybody learned every minute. Every minute was worth it. So congratulations, everyone.
Thank you. Thank you so much. Actually, the Wire Pearls, they get circulated on social media at regular intervals. And what we are planning is that all the pearls that we have collected, gradually over the next few months, we will be circulating it one by one on the social media so that we can have everybody view it. And we will, of course, put them all together in print form as well, as Dr. Feroz suggested, and so that we can have it in one place. And we'll do it for other specialities also. This was just the first phase. That's our intention to go forward with it, right?
I'm not
And
sure.
Yeah, Che, please go ahead.
I'm not sure if you are familiar with the Made Ridiculously Simple series. So there's this book that I used to read when I was a resident. Maybe you can like Google that and because all the pearls are very simplified already. So maybe you
right,
can do like mnemonics and all to make it more easily to be remembered. So there.
right,
So
sure,
nice.
right.
Yeah.
And we
Another
would
suggestion is, as I said, please open membership for biological YOSI group. Usha,
Ma'am.
Dr. You can all join. This is such an enthusiastic group. Biological YOSI, okay?
Biological YOSI, yeah,
But it's
absolutely.
all about how we feel, Dr. Fairuz.
Exactly, Dr. Che.
Right. Thank you, ma'am. And Dr. Sahil, may I request you as well, if you're still around, to give a few words? Dr. Aditi, you're right there. You've been one multitasker, mother as well as oculoplasty surgeon. So can we have some comments from you and then Akriti ma'am as well?
Yeah, thank you. I think this is my first webinar back after maternity leave. I have a 6-month-old at home, and thanks to Rolika and Team Yosi for getting me back on the track. And it just made me realize how much I missed this academic discussion. And on a lighter note, if we could finish so many presentations in a minute, do we really need to have long webinars? If everybody can shorten their slides to 2 to 3 minutes and give us pearls like this in every
Exactly.
webinar, our attention spans would be amazing, I think.
Yeah,
But of course, the
absolutely.
concept is absolutely amazing. And like Usha ma'am said, Ashok sir said, everybody has learned. Everybody has a take home from this, whether we are junior in the field or senior in the field, we've taken some pearl back home. Thank you once again.
Thank you. Akriti ma'am, thank you.
Thank you so much, Rolika. When you reached out for the first time, I responded immediately without asking anything. But this, I was pleasantly surprised. This was so engaging. And this 1 minute thing, kind of, I'm sure everyone was attentive all through. Nobody kind of zoned out, which happens in some of the long drawn webinars. So I think it's a brilliant platform to be inclusive and very heartening to see that right from postgraduate, we have so much enthusiasm in presentations for oculoplastics.
Thank you
I
so
hope you
much.
continue.
And I would just like to highlight that all the way from our senior most, Dr. Grover sir, Usha ma'am, And all the way to the junior most budding residents, we kind of have everybody in oculoplasty on the same panel. So I think that's a win-win for all of us. So thank
Absolutely.
you, everyone. And over to you,
We'll take
Nupur
a
ma'am.
we'll take a quick group photograph till Dr. Shruti gets ready with her presentation for the keynote lecture. I'll just request everybody to switch on their videos. And Manjula, you can take a photo for us and we can do the yo sign.
Sure,
Can we request everybody to quickly switch on the video? Yeah. Yeah. Surbi? Manjula, can you take the click for us?
Sure, doctor.
Yeah.
She'll have to take 2 screenshots. The 2 screens full.
Is it done, Manjula?
Yes, doctor.
Yeah, we're done? Yeah.
Yeah. Over to you, Nupur ma'am.
Oh, yeah. So Prasanna, can you introduce our keynote speaker? And I'll request everybody to stay
Yes, ma'am.
back. If possible, Rolika, we can try to announce the winners
I'm
also.
on it.
Yes. Yes.
Thank you.
Yes,
Thank you,
yes.
Nupur ma'am. So we have
Yes.
this webinar series again partnered with JB Pharma, and this is started like a small mentorship idea, and now to have more people. It started between Rolika, Anujit, and myself, and now we have Arshi, Nupur ma'am, Sunandini. We are covering all series as much as possible. And today we are doing the oculoplasty. And to touch upon some of the latest advances of innovator molecules, Dr. Shruti ma'am is going to talk about a story of an innovator molecule. And she's a pediatric ophthalmologist, a very avid researcher. She's into PhD, and she's one of the persons I look up to when it comes into research. And over to you, Shruti ma'am. We are all looking forward to hearing from you on the molecule. Yeah.
Thank you, Prasanna. Thank you, YOSI, for the opportunity to present here. So I am just going to share my screen. So I'm just going to, this is a beautiful webinar on oculoplasty, and we're just slightly shifting gears to ocular allergy. And this is a talk on allergy in pediatric patients. So I think ocular allergy is something that we've all been seeing, and it's part of our practical case scenarios per day. At least we would see 2 to 3 young adults or kids on ocular allergy. So this is just something that I would like to talk about today. And I just want to remind you that this is a molecule that is from the JB Pharma. So I will be talking about a molecule from that. So to begin with, we all know that allergic reactions are very common in pediatrics, and almost 40% of the children, almost 40% of our OPD in kids have some form of allergic conjunctivitis. So it's very prevalent, and yes, yet it's a big spectrum. Like there are very mild cases to really severe cases where we really don't know what to do much. So with, considering that spectrum, then there are 2 types of hypersensitivity reactions that can primarily be associated with this. And so type 1 hypersensitivity is what is stimulated by the IgE, where the allergens actually bind to the immunoglobulin E antibodies on mast cells, and then they kind of stimulate and produce histamine, prostaglandins, leukotrienes, and other mediators. And that in turn causes vasodilation, itching, and the local permeability, increased local permeability. Now, then there's a type 4, which is, I'm sorry, this is a typo. The type 4 hypersensitivity, which is a T lymphocyte and the macrophage induced delayed cell-mediated response that can also happen a little later. So these are the 2 responses that are usually seen. Now, when we look at the prevalence, it's about 30% of children. And in India, 7.6% of kids who visit our OPD have ocular allergy. And the most common age group is between 5 and 7. Now, it also is something because of the spectrum of the disease. It can really be quite a debilitating disease, as most of us would have seen in clinic. The parents are frustrated, they're flustered, they really don't know what to do because the child doesn't have a good quality of life. It affects the sleep, the daily activities, physical, mental well-being, their mobility, as well as their social functioning. And sometimes, it just changes the facies so much that, they no longer look fresh anymore. What is important to understand is that allergic conjunctivitis is not just one entity. It's a spectrum, as we see, and there are different entities which have certain very characteristic features between them. So it is important to differentiate them. So let's start with seasonal allergic conjunctivitis. This is one of the most common forms where we see some children come in, especially during the pollen season, the winters and some early spring seasons, where they come in with the allergic conjunctivitis, usually triggered by exposure to pollens, and that usually during the spring season especially. And the second is the perennial conjunctivitis, which is the same as seasonal, except that it is chronic and ends up having symptoms throughout the year. And it's induced by dust mites, fungi, and other occupational allergens, and pretty much occurs throughout the year. Then you have the vernal keratoconjunctivitis, which is a self-limiting disease, and it's slightly different in the sense that the kind of inflammation that occurs is a chronic allergic one, and it affects it. It typically you can see these cobblestone papillae in the superior superior pharyngeal conjunctiva, and that kind of is one of the really typical features of VKC. And then you have the atopic keratoconjunctivitis. Now, the difference between the atopic and the other forms is that there is going to be some form of skin involvement, and that's the primary difference. So usually it's associated with some form of, skin hyperpigmentation or some form of wrinkling, or they are associated with meibomitis or some form of inflammatory disease of the lids as well, and along with some like atopy, like asthma and eczema. So they have some form of allergic symptoms other than your pure eye symptoms. And of course, the giant papillary conjunctivitis, which is not a true allergy, but rather an irritant phenomenon, which affects again the conjunctiva, which causes it to have giant, medium or small size papillae in the palpebral conjunctiva. So now these are the types that are usually seen, and it's important to, whenever you see a child in the clinic, to kind of categorize them into these into one of this group. Now, when we look at the etiology, of course, in our part of the continent, we know that there's a lot of allergens that are readily available. The pollution is there, and not just that, we have a lot of dust and other triggers as well. But when we look at typical seasonal allergies are probably due to tree pollen, grass, and any of these kind of dander that are there, that's usually seen in spring, late summer, and fall. The perennial allergies are the ones that are usually seen because of the pollution, the dust mites, and the animal dander. The vernal keratoconjunctivitis, again, is a mix of triggers are there, but whatever the trigger is, the presentation is a little atypical compared to the seasonal and the perennial. Now, the allergic conjunctivitis is correlated also with endochemical compounds. Sometimes the cleaners that we use, or the bed cleaner, bed washing liquids that we use, may also trigger them. And also they're associated with reduced levels of weekly physical activity. Now, among Indian children, exposure to dust has been found to be one of the main causes of allergic conjunctivitis. So how do they present? Now, let's look at a very quick overview of how each of these are a little different from each other. Of course, when they present, the seasonals are intermittent, whereas the perennials are persistent. VKCs can be persistent with intermittent exacerbations that can happen. Atopic keratoconjunctivitis is also chronic, and GPC can also be persistent. When we look at the eyelids, almost all of them can present with edema, whereas the VKCs have pseudotosis because of the superior palpebral conjunctival changes. The AKCs tend to have eczema with meibomitis, blepharitis, and so on. When I look at the conjunctiva, the main thing about VKC is the giant papillae, which can be seen between VKC and GPC. And the AKC is where you have the papillae. The papillae is a very typical finding, which is because of these septae, or the fenestrations that are seen between the conjunctival cells. And that typically causes it to give this kind of a cobblestone. When we look at the limbus, the VKCs, of course, have the Horner-Trantas dots, whereas the GPCs would have hyperemia. And more often than not, the corneal symptoms do occur in VKC and AKC, with you have these typical shield ulcers, the vernal plaques, the opacities, and also sometimes superior neovascularization and pannus. So having now separated these four entities, let's look at the diagnosis. Well, diagnosis pretty much straightforward. You look at them and then this is kind of there. It's not conjunctivitis. It's definitely looking a little different. you need to establish a very clear medical history about what are the triggers, what are the environment the child is in, is there any pets, is there any dust, is there any loose sand or anything that the child is being exposed to. Sometimes chalk piece dust or fine cement dust, a nearby building work or something like that could also be a big important trigger. Sometimes wind in our part of the country where pollution is quite significant, just wind in the eyes can also be a big trigger. So we, kind of tell children to sit behind the parent in the two-wheeler, or maybe do not throw their head out of the window when they're in a moving car or a vehicle. So these are all simple things that can kind of exaggerate it. And of course, you look at the evaluation of the signs and the symptoms and how severe the issue is actually for the patient. So you also important is to look for the eyelids, you look for blepharitis, dermatitis, look for any meibomian gland dysfunction, which could actually worsen the things and not allow for a complete cure or a treatment of the issue at hand. Look for demodex infestation, swelling, any form of discoloration or spasm. Some of these children tend to have even skin excoriations, and some of them tend to have hypopigmented eyelids as well because of that, because of the atopy. And also important to look at is the palpebral and the bulbar conjunctiva. Look for hyperemia, papillae, any form of secretions. The kind of discoloration sometimes you see below the eye, it's called the allergic shiner because of the constant rubbing. You look for mild to moderate conjunctival injection, chemosis, and periorbital edema. So how do we differentiate? Well, I'm not very sure this slide is important because, it's pretty simple what you look at, between bacterial and viral and also allergic conjunctivitis. So if there is any form of pain, then it's definitely probably not a form of allergic. If there is photophobia, well, sometimes it can happen in allergic, but most probably is something got to do with the cornea and bacterial or viral keratoconjunctivitis. If there is itching and if there is discharge, if there's a ropey discharge, and if there is some limbal changes and there's a muddy conjunctiva, then you're definitely looking at allergic conjunctivitis. And again, a repeat of the same, the symptoms and the signs of it. Again, most of us would be very clear with this presentation. Now let's move on to impact on the quality of life. So we do know that most of the parents in a practical scenario come to our clinic with frustration. The children are tired. They don't want to keep moving between school and clinic. They take off on the bad days. They visit the clinics often, and the parents are just like, is there anything else we can do for our child? So definitely there is a quality of vision problem associated with this disease, and the quality of life as well is also terribly affected. There is definitely a physical and a psychological impact. It also affects social functioning, and most of the kids do have some form of withdrawal, or do they underperform in school, and they're a little conscious of the whole condition that they are undergoing because of the chronicity. So let's look at management approaches. So obviously the most important is to prevent and to use simple interventions like cold compress, use lubricating agents, and minimizing eye rubbing. So I usually recommend them to wrap ice cubes in a towel and just put it on their eyes, or just wash with cold water, and that would really help. Of course, the first line are topical antihistamines with plus or minus mast cell stabilizers. The second line would be topical corticosteroids. I wouldn't say less than 7 days, maybe a little longer course. But then, of course, they need to have probably cycles of it on a repetition. And of course, after multiple cycles of steroids, if they really seem to be recurring, then we go on to the third line of immunotherapy. So again, an exhaustive list of the drugs that are available. Let me just quickly run through. We have topical decongestants that we use. The phenylephrine is what we call tetrahydrozoline. Phenylephrine is something we commonly use. Systemic antihistamines, topical antihistamines, mast cell stabilizers, cromolyn, and so on, and antihistamines like nafazoline. And of course, all of these have different modes of action, but what we are going to focus on is olopatadine, because that's the molecule that we're going to talk about today, which is from JB Pharma. And the NSAID, that is the NSAIDs, can also help. And of course, corticosteroids, especially loteprednol, which in my practice I find very effective. And I use it regularly for all my patients. So again, allergens avoidance is very important. So we look at, I've already discussed all of this, lifestyle adjustments. We look at the child, avoiding loose sand and beach sand and all of that also helps. So we tend to kind of modify the kind of environments they're in for a short period of time. Now let's move on to the drug, the molecule as such. Now we know that olopatadine 0.1% exists in the market, but we're going to talk about 0.2%, which also exists. but just the molecule itself is really good. When we look at the itching scores, and we see that clearly between placebo and olopatadine 0.2%, the difference is starkly there. It's statistically significant, and children claim really good improvement over a 16-hour duration of action. You can see that even at the end of 7 minutes of application, the drops seem to have a really good resolution of the itching per se. When we look at the redness scores, then again, you can see that at the end of 20 minutes and over a period of 16 hours, again, you see the olopatadine 0.2%. And this is the dosage of it is just once a day, probably in the morning, just before they head out to school. Really do well compared to placebo. Again, really good results there. When we looked at the frequency of ocular itching and the frequency of ocular redness, much lower with the olopatadine 0.2% versus the placebo over a 70-day period. Again, this was a 10-week RCT that was done in around 250 kids. And you can see the, yeah. When we looked at satisfaction, again, this is important because ultimately it's a very subjective disease and a lot of patients need to feel better with it. And the subjective scores are quite good. If you see that at the end of day 28, 0.2% olopatadine, 87% of the kids were quite satisfied, and the parents were also satisfied with this treatment. So olopatadine 0.2% seems to have a much better effect than the 0.1% and a better dosage and a better compliance with regards to the application times. It's just once a day. So the clinical assessment confirmed its 24-hour duration of effectiveness, and it is also statistically significant. So olopatadine 0.2% is something that I regularly use in my clinic as a first-line treatment for allergic conjunctivitis. And I use it once a day for children who have mild to moderate, but I don't hesitate to go twice a day also in some patients who I think are slightly on the severe side. And that again helps when we move it a little higher in dosage. So again, repetition, it has rapid onset of action, it reduces symptoms, comfortable and improves quality of life, and it is safe for patients as young as 2 years. And that is very true because I give it to really young patients, and again, absolutely fine with that. So obviously allergic conjunctivitis is a chronic condition, so we need to bring in these kids again for regular checkups and keep monitoring them, because sometimes there's going to be this subclinical inflammation that sets in, and that can set up astigmatism or progressive keratoconus in the future. So we need to keep a lookout for repetitive checkups, so that we look out for eye rubbing and all of this, in spite of the patients saying I'm feeling better. But sometimes the parents can kind of miss this rubbing habit and this astigmatism, and that's something we need to keep looking out for. So here are the key takeaways. Allergic conjunctivitis is a very prevalent ocular disease that we see in pediatric age group, and especially in our part of the countries and certain communities, it's very common, and it's probably most likely a reaction to allergens. It's important to evaluate the signs and symptoms and probably put them into one of the buckets what we discussed, and based on that, it's easy for us to kind of follow them up, and we know how the course of the disease is going to be. Allergen avoidance in pharmacotherapy is very important. Of course, here they didn't touch about immunotherapy, but I do like to give tacrolimus for most of my patients who do not really sustain with corticosteroids. Maybe after 2 or 3 course or cycles of steroid, I easily shift them to tacrolimus, and they do really well. And of course, mast cell stabilizers, lubricants, and all of them form a very important part of the support system. So olopatadine 0.2% once a day, and in severe cases twice a day, also do well. So thank you so much for your patient listening.
Thank you. Thank you, Shruti ma'am. On short notice, less than 24 to 36 hours. Thank you for being here, and for being here for YOSI, as well as this innovative series that we are actually doing. So thank you, ma'am. And Nupur ma'am, with your permission, if there is Mr. Vivek from JB Pharma.
Yes, sir.
Thank you. I think I was just speaking to Mr. Akash Gupta as well.
Yeah.
A few words from you, sir. I think this has been a 3-series event that we are doing. So we started with glaucoma under the leadership of Arshi. Then we went to cornea with under the leadership of Sunandini. And here we are with the collective leadership of Lipi, Rolika, Nupur ma'am, and the whole oculoplastic group, Punit et al. So we have just covered an A to Z capsule of different innovative module where we have brought 2-3 collaborative groups. So Vivek sir from JB Pharma, if you can have a few words.
Definitely, sir. I would like to thank everyone, starting from you itself, sir, and Shruti ma'am, Rolika ma'am, Nupur ma'am, Lipi ma'am. Thank you, everyone. The series have been going through very well, I think, and it's just because all of you are chipping in and taking out the time and providing this insight. It is very good to see that, and with the YOSI platform, we are always there to help, always there to uh, support these kind of academic initiatives, and we will continue to do the same.
Thank you, Mr. Vivek, for being our premium industry partner for last year's YOSICon, and we really look forward to more such collaborations for our young ophthalmologists as we are taking forward with more vigor and energy this year for the International YOSICon 2026. And speaking on behalf of the whole GC and YOSI family, and handing it over back to the moderators, Lipi, Nupur ma'am, to take it forward and do the proceedings.
Yeah. Lippy, can you thank you, Mr. Vivek and JB Pharma for that, for the collaboration. Thank you, Dr. Shruti, for a wonderful presentation. It was excellent, and thank you so much. And it's a very, very, very important topic, especially I think in the area of Delhi NCR, where we face so much pollution at this time of the year. We see so much, surge of allergic conjunctivitis. So this was a very, very, and you covered it and you explained it really well. Thank you so much. And thank you, JB Pharma and Dr. Prasanna for having this for us. Lippy, can you share your screen once? Rolika, are we good for the?
We do have the the results already, but till
Do you want to
Lippy's-
cross check? Do you want to
I'm
cross
just
check it again?
cross-checking because I like
Okay,
to
so
be
we'll just have a few
doubly-
comments. Yeah. So Lippy, can you share your screen?
Yes,
And
ma'am.
yes. So Anujit, who's our BioPulse team lead, could not join, but we had the team of Yugandhar. Yugandhar, are you there, Dr. Yugandhar? If you're there, can you just unmute yourself once? Yeah.
Yes, ma'am. I'm here.
Yeah. Lippy, can you share the screen once?
Yes, ma'am. I'm
Yeah.
doing it.
Okay. Yugandhar, so a few words from you about this BioPulse initiative. Can you just appraise the audience, what it is all about and how they can submit, and what was your thing with the webinar? So, yeah. So
Yeah.
can we go? Yes. So let me just introduce the BioPulse team. So So this is a very great initiative which Dr. Yugandhar will tell you about, and this is a team which is being led by Dr. Anujit Paul and Yugandhar and Dr. Tanveer. And I must say that Dr. Yugandhar and Dr. Tanveer have been instrumental in this webinar, very instrumental. They fantastically collated all the pearls and did a fabulous job and did excellent moderation. Thank you both of you so much. So over to you, Dr. Yugandhar, about the BioPulse.
Thank you so much, ma'am, for having us first of all and giving us this opportunity. So our team BioPulse, so Dr. Anujit sir, he is the team lead basically. And this is one initiative in which we, every Sunday, there is one pearl, like how we had today oculoplasty pearls. In the same way from all the subjects, basically we have this one short pearls which we release every Sunday. So we have this one email ID, which is for, especially which is given for the YOSI pearl. So whoever is interested, they contact us through WhatsApp or they directly email us on our email ID and send their pearls there. So it can be related to anything short and sweet, which is useful for everybody, right from a first year postgraduate till a consultant who is practicing ophthalmology. So we are getting really, like everybody has been appreciating about the same. So we are very much happy and more motivated to do this work. And as Dr. Feroz ma'am had suggested to, kind to collab whatever we had today. So, hello?
Yeah,
Yes,
yeah,
yes, we can.
audible.
Yes,
You're audible.
please
You're
go.
audible.
Yeah.
So I think we definitely want to take this forward. So this is going to help everybody, like not just postgraduates, but this is for everybody who is practicing ophthalmology. And I would like to thank Dr. Anujit sir and Dr. Tanveer for always being there in our YOPulse team. and he has been the team lead basically. And all of you, Dr. Prasanna sir, Dr. Nupur ma'am, Dr. Lipi ma'am, Dr. Rolika ma'am, congratulations to all the participants over here today. Thank you for presenting, and also all the panelists, the judges, all the moderators here, the chairpersons. It was great. Today's session was really nice. Thank you so much for having us here.
Thank you, Dr. Yoganda, Dr. Anujita, and Dr. Tanvi for a great work with the BioPearls, and we hope to see this more collaborations with the other specialties also, and probably a next edition with oculoplasty as well. So, yes, Rolika. So, are we, or you still want us
Yes.
to?
No,
Are we?
I'm good with the results. Would you like to announce it?
No, you please go ahead. Yes, please go
Okay,
ahead.
perfect. And how many positions do you want me to announce? That decision goes to you.
Prasanna, we can have 5. What
Yeah.
is your take? Considering
Yes,
we
ma'am.
had so many entries, top 5
Definitely,
can
ma'am.
be, and we'll be awarding them at YOSICon in a proper
YOSICon.
award ceremony. Yes, yes,
Yes,
yes.
ma'am.
And we would really love to have our our judges and panelists, Dr. Grover sir, Dr. Usha ma'am, Kasturi ma'am, if they can join us, in person to give away those prizes at YOSICon for the pearls. So, Rolika, over to you. Everybody's just waiting for the
Ma'am, and
results.
Yes.
quick announcement before the results, ma'am. If again Dr. Yugendra Anujit is not here because of inevitable reasons, if you guys can mimic something for the physical UCCon, something of this sorts, Yopal, a flash note kind of a concept, each single minute. I think many seniors commented very positively and optimistically where
Yes, sir.
just a minute, but you are able to convey more. Less is more is what is the order of the day. I think if you guys can come up with a
Yeah,
session
I
by
think
this
this is a great concept, sir. I think we would like to implement this in the upcoming YOSICon. So we'll definitely have a word with Dr. Anujit and take this forward.
Yeah,
But thank you so
brainstorm
much
and
for.
Dr. Prasanna,
yes,
just
sir.
a word.
Yes,
We
sir.
have converted our entire World Congress, World Society of Oculoplastics, into 3-minute presentations for everybody.
Yes,
And
sir.
with only 15 minutes to 12 to 15 minutes for all presentations, followed by a 30 to 40-minute discussion. I think that
Nice.
has worked beautifully for the last 2 conferences. And as chairman program committee, I really was happy to do that, and the results have been marvelous. It's very, very well received. So I
I
think we
agree,
must
sir. We were,
shift more and more to panel discussions
Less is
and
more. Yeah.
get the concepts from the talks.
Thank you.
yes, sir. I've been in the audience and I agree with you, sir.
Rolika, back to you. Yeah. For the
Okay, so we do have our results, and you said we can have 5 positions?
yeah.
Top 5. Yes,
Top
Top
yes,
5.
yes.
Okay,
Yes.
so at 5th position, we have Dr. Reema Seth. And so, congratulations. And very clearly, she bagged the 4th position as well. So, we are being very fair that if a person is able to bag 2 positions, then she's bagged the 4th position as well. At the 3rd position, we have a tie. We have a tie between Dr. Neha Ghosh and Dr. Vrashika Patel. Yes. Okay. And at the 2nd position, we have Dr. Renu Chaudhary. Congratulations, Dr. Renu Chaudhary.
Yes.
Is everybody
Thank you,
there?
ma'am. Thank you,
Okay.
ma'am.
Yeah, please turn on your videos and show some
Videos we like.
enthusiasm.
Yes, yes.
And at the 1st position, we have Dr. Resham Bhatia. So,
Congratulations.
congratulations.
Thank you, ma'am.
Congratulations,
Prasanna,
everyone.
can we have one more position since Dr. Reema is back, both the 4th and 5th, just one more person? You think we
Sure,
should
ma'am.
give a
As long as they make to the physical
So let me
YOSICon.
make it fair. So I think we can at the 4th position we have Dr. Reema Seth. Okay.
Ha,
And
yeah,
at the 5th position we have Dr. Surbhi Shalini.
Congratulations.
Perfect.
Yeah.
Perfect.
Perfect.
Because she
Yes.
landed up having the 6th position tie as well. So
Yes,
fair enough.
yes,
So we
yes,
have
yes.
our top 5.
Perfect. Excellent.
Done.
And I'll just repeat it for everyone in the order of going upward. It's Dr. Resham Bhatia, Dr. Renu Chaudhary, Dr. Vrashika Patel, and Dr. Neha Ghosh at the tie, Dr. Reema Seth, and Dr. Surbhi Shalini. Congratulations to everyone and a
Congratulations,
wonderful
Anne.
job by all the participants. We loved it and we will have you in a book.
Yes, and kudos to all the participants. I think everybody's a winner. As we keep saying that, contest is just a formality, just to make you put your best foot forward and to have a little zing of enthusiasm. But everybody, each of you is a winner, and so much learning. And we look forward to having more of this and having all of you keep participating over and over again. Congratulations to all of you. Kudos to all of you. Yes. So
Congratulations.
also I would like to mention a special thanks to, I think, Dr. Lippy Mittal. So she's neither a part of the Bio Pearls group or the Oculoplasty focus group, but she's, I think, one of the most dynamic YOSI executives, and kudos to her efforts for putting this all together. She's been the backbone of this webinar. I can safely, along with Rolika, obviously she curated the entire flow, all the mark sheets, the presentations. Thank you so much, Lippy. Thank you so much. It was, that one silent, Prasanna keeps saying one woman army. You did it in CCC yesterday, and today you're here for us for the unconditionally here for this program. Thank you so much from the bottom of
It
our
is
hearts.
absolutely my honor, and I would like to thank you and Rolika ma'am, especially both of you. You guys were the backbone of this event. I was just helping you from the back end, and
I think that was the
kudos
biggest
to you
thing.
guys for organizing a very well event. Thanks to you. Thanks
It
to
wouldn't have been
Prasanna sir.
possible without your efforts, Lippy. You were there to, just, what do you say, like a pillar, like holding up everything. So thank you, Lippy. Thank you so much. So special mention.
Ma'am, again, another special mention from my side, Shruti Nishant, ma'am. Last
Absolutely.
24 hours, I think
Absolutely, Shruti. Thank you.
I
Thank you
kept
so
it
much.
very candid, ma'am. This is where we really want you to fill, and it is not a specialty webinar. Like, madam is a pediatric ophthalmologist trained in SN, and I told ma'am that, ma'am, you have to be there for us, and she's like, okay, fine, we'll do it. And I just, it all started rolling, and I think Nishant sir was also, Nishant sir, everybody knows sir very well. So he was actually leading the YO task force till he was a YO. He still thinks he's a YO, but
Somehow he's still part of you, and I don't accept it.
yeah. So now I think we are disturbing Shruti ma'am a lot. And ma'am, I think the keynote lectures, we had Mainak for the first event, and we had Dr. Tushar for the second in cornea, and third we are having you. And all the three people, and we have one more to go with JB Pharma. I think all three of you guys, I think all are Wonder Womans. Nupur ma'am.
It's the least. Actually, the
Like,
effort that you guys put, I was just there for the webinar. So great going, guys. I mean, I'm so proud of the YO team.
Thank you, ma'am. Thank you. Yeah, Nupur ma'am, Rolika, Lippy. And again, would like to acknowledge Rolika and Anujit ma'am. It was a very passive discussion. I was a very passive spectator between Rolika and Anujit when they both conceptualized this whole idea. We were thinking about competitions, but then it was a mentor-mentee. And now to see all the groups, Oculoplasty, glaucoma focus group, as Dr. Puneet was telling, we did have the focus groups now taking in charge under the Vakan sir's leadership. Each focus group coming out with gig under Arshi had a standalone physical event last week in Dehradun. So I think each focus group is now taking leads. Again, pediatric, Shruti ma'am, Aditya Sethi, collaborating with WPSOS. I think the future is very bright for all the subspecialty groups as well. Thank you, ma'am.
Absolutely.
We have leaders like you who always say yes for everything. That's why we end up doing everything.
And they encourage so much. No, it's always positive enforcement and
Ma'am, I'll
You
just
don't
give it back.
say you are
I'll-
no less because
give
I
it-
just called Nupur, ma'am, we want to do something. And she comes up with bubbling with ideas. Let's do this. Let's do this. You
Yeah.
can collaborate pearls with Oculoplasty. Why can you not do this? I mean, come on. It's, I think, the entire team which always lands up saying yes. And I think I want all the postgraduates also to learn the same thing. Please make sure that you have people and colleagues of the same vibe and the same frequency who land up telling you, yes, go for everything. So you want to grow together, not against each other, along with each other. So all the best.
Yes. And thank you to Yogander and Tanveer also.
Tanveer.
Fabulous.
Yes.
I think they quickly collated everything, and fabulous moderation. Thank you,
Thank you
Yogander.
so much,
It was
ma'am.
fantastic.
Thank you so much for having
Yes.
us.
It was our pleasure, and I think just one message I put, and both of them were up to it. They
Yeah,
they
Yeah,
did
always.
it.
No, but I think
Fantastic.
this postgraduates, like the young ophthalmologists, their confidence really goes up when we actually
Absolutely.
do such sessions. I think that's amazing.
Absolutely.
Ma'am, and numerotech as well for their
Absolutely. Yes, that is the most important, I
numerotech.
think. Manjula ji, Mr. Sai, absolutely. With all, prompt within 2 days, within a day's notice, they are ready with the links and the Zoom backdrop. And absolutely. Thank you, Manjula. Thank you. Thank you always for the support. Thank you. Yes.
Thank you, Doctor.
Thank you. So I think that was wonderful. And with this, can we call it a wrap? It's
Ma'am, I think we can go off live if we are done with
yeah,
that.
please
Yes,
can
One
yes.
second, Doctor.
Yeah.